And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be dialysis there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child, diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective, or missed in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of Medi classes 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. So what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting, but what is, and you can simultaneously assess bone age there. So it looks very simple. You're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis, this is the investigations required, this is the likely treatment, and then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken, you will get results, interpretation. This is a work in progress. A lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases in which a lot of interactive discussions.
We'll be talking about DXA, which we all know is a newly emerging diagnostic modality gradually reaching our clinics. So why we need this bone mineral density assessment is a very important question. Should we use it as a routine automated procedure, or do we need to have accurate indications which need to be done in a proper methodological manner and precise interpretation? So our first question will be, why do we need bone mineral density assessment in children, or to say in any individual? So we all know that there is a variation in the bone mineral density across the lifespan, with peak bone mass being attained at around late 20s or around 20 to 25 years. And thereafter, there is a gradual annual loss of 0.3 to 0.5% beyond 30 to 40 years of age. And this exponential loss is more pronounced in females, particularly due to the loss of estrogen hormone after the menopause. So coming back to the historical background, before the advent of DXA, how did we measure this bone strength? So historically speaking, X-ray was the first modality which was used to estimate the bone strength. But so X-ray could only assess the bone structure and could not give any information about the bone strength. So after X-ray, we had the functional modality known as the single proton absorptiometry. So as the name, so shall I wait?
Let's come.
So as the name suggests, it had a use of a radionuclear agent known as iodine-125. But the drawback was that it could only assess the bone mineral density of the appendicular skeleton or the forearm and the calcaneus. A decade after, it was substituted by a double proton absorptiometry, which used gadolinium as the radionuclear isotope scan. And it was for the first time that the central sites such as spine or proximal femur could be assessed using this double proton absorptiometry. A decade later, that is around 1980s, we had the advent of dual X-ray absorptiometry. So the advantage was that the radionuclear agent which was being used till now was substituted by X-ray. And this DXA could be used to measure both the peripheral sites as well as the central sites. Then we have a whole array of radiodiagnostic modalities such as CT scan, ultrasound, MRI, but most of these are mainly for the research purposes. And among all these radiodiagnostic modalities, DXA stands as the gold standard, mainly because of the following advantages. That is, it is associated with a low radiation exposure, making it a safe diagnostic modality. The scan time is somewhere around 1 to 5 minutes, so that it is a quick OPD procedure. And it is associated with high precision value, although the precision varies with the brand that you are using and the site that you are estimating, which we will be talking in the subsequent slides. So coming to the first advantage, which is the low radiation exposure. So as we see that the National Osteoporosis Foundation, the data published in 2004 showed that the effective radiation dose, which is delivered while doing a spine or whole body DXA with the number of, as you can see on the right, the number of machines that are available with us, such as Hologic, Luna, Norland, is far below the radiation that normally occurs in the United Kingdom, which is 6 to 20 per day. So it is quite a safe procedure as far as radiation exposure is concerned. So what exactly is the principle behind this DXA? So first we need to understand that the DXA is abbreviated as DXA and not DEXA. So the first thing which should go after this class is DXA needs to be abbreviated as DXA, and please don't write it as DEXA. So the principle behind this DXA is that it uses 2 photon energy beams. So these are 2 different photon energy beams which have different absorptiometry capacity. So just similar to ultrasound, what happens is that different tissues have different radiation absorption capacity, so that a different film is created for bone, organ, air, fat, fluid. Similarly, in DXA, there are 2 different energy photon beams which are being used. So depending on the quality of photon beam, it can either be a pencil beam, a narrow angle fan beam, or a wide angle fan beam. So the initial DXA machines had pencil beam technology, and as the technology is progressing, the newer machines have the wide angle fan beam. And the advantage is that if you have a wider fan angle beam, the time taken for DXA scanning is less. So with pencil beam, the time was somewhere around 5 to 10 minutes. And with the newer technology of wide angle fan beam, because since you can cover a larger body surface area in a quick span of time, the time has reduced to less than 1 minute. So DXA, as I said, could assess both the peripheral as well as the central side. So peripheral DXA is a portable machine, as we can see here. The reproducibility and the precision is not as good as central DXA, but it can be used to shortlist the candidates which will ultimately require a central DXA, or it can be used in setups where central DXA is not available. So with the help of peripheral DXA, we can measure the bone mineral at sites such as distal radius and calcaneus. And central DXA, which is used on a stationary scanning table, is used to assess the bone mineral at sites such as spine, femoral neck, distal radius, and whole body. So talking about what are the different sites analyzed and which site should we prefer being a pediatric endocrinologist. So the different sites which can be analyzed are spine. So among the spine, we have the L1 to L4 section. So this can be used in children as below as 0 to 5 years of age. The next scan we have is the whole body scan, which is used in children more than or equal to 3 years of age. Then we have the proximal femur or the femoral neck, which is used beyond 18 years of age. These age cutoffs are because of the presence of the database which is available. So for children below 18 years, we do not have a globally accepted database. And that is why, as of now, we are saying that this needs to be done in children beyond 18. Maybe down the line, we can use it in less than 18 years as well. Then we have the distal radius. The indications for doing distal radius is morbidly obese patients who cannot be accommodated on a scanning table, or hyperparathyroidism, because as we know that the changes in bone mineral density in case of hyperparathyroidism occur prior in the appendicular skeleton as compared to the axial skeleton. So if you have a case of hyperparathyroidism, consider doing a distal radius scan rather than a spine or whole body scan. So coming on to that in-depth, how to acquire these scans, because this is not an automated procedure where you just write, do a DXA spine and the report will come out to you. You need to have orientation, how to make your patient lie on the scanning table, how to acquire the images. So a great knowledge is required in terms of technicality and the image acquisition. So the figure shows here the patient positioning. So you have to make the patient lie down supine, and then a positioner is placed below the knee so that the spine comes down as close to the scanning table as possible and also eliminates the lumbar lordosis which is present. So we need to place the scanner in between the L1 to L4 vertebra. So this is the region of interest that we are interested in. So as you see that first, it needs to have all the L1 to L4 vertebra in the region of interest. The L5 vertebra upper body should be included. and the 12th thoracic vertebra with a pair of floating ribs should be visible on the image. So this is the correct positioning with the correct region of interest. Any metals or implants or osteophytes presence needs to be eliminated while interpreting the result. So if among the L1 to L4 vertebrae there are any fractures, any implant, that particular vertebra needs to be excluded from taking out the average BMD, and we need a minimum of 2 lumbar vertebra to get the average. So let's check if you can identify the potential errors which are present here. So on the left extreme, you have the correct positioning of the spine scan. The middle image shows you a rotated scan. So if you get a DXA result which shows a rotated spine, there is no fun in analyzing this result. You need to do it again. So this is the image which shows the presence of 6 lumbar vertebra or 6 vertebra along with a thoracic vertebra. So this will also give you a false result. You cannot interpret, diagnose or manage based on this DXA scan. So the main difficulty that arises is in identifying the vertebra, which is a thoracic vertebra, which is a lumbar vertebra. So this is a pictorial representation of how a lumbar or L4, L3, L1, L2 images appear on a DXA scan. So you can compare the images given on the pictorial side along with the one which are acquired from the DXA. So as you see, L4 appears like a butterfly image. So you have to count from below upwards rather than from above downwards, because your 12th thoracic vertebra can have a similar anatomy as the lumbar vertebra. So you need to count from below upwards. So this is a newer concept of vertebral morphology assessment which is coming up. Till now, we have been saying that you need to measure L1 to L4, you need to measure L1 to L4. But studies have found that compression fractures at the level of thoracic vertebra, they have a higher relation to the occurrence of fracture risk in the future. But till now, we were not seeing the thoracic vertebra. So the newer DXA machines have an advantage of giving you a vertebral morphology assessment. So just have a look at this image which shows compression fracture at the level of T7 and T9, but with a normal lumbar vertebra morphology. So if we were to assess only the lumbar vertebra in this patient, we would have declared it as a normal patient. But it is found that pubertal patients who have idiopathic juvenile osteoporosis or vitamin D deficiency, they have a propensity towards thoracic vertebra fracture as compared to lumbar vertebra. So in adolescents or per se in any pediatric patients in which you are considering a high risk of osteoporosis, always write a vertebral morphology assessment along with a DXA. Similarly, as we write a FRAX assessment in adults, a vertebral fracture risk assessment for adults. So this is a newer concept for diagnosing pediatric osteoporosis. So this is how a report derived from DXA looks like. So it will show you a region of interest in which you have to check whether all the proper vertebral images have been taken or not. Is there a rotation or not? Is there any metal implant or osteophytes? Then you get the bone mineral density in absolute numbers along with the pictorial representation as shown in the traffic light signal pictorial, green, yellow, and red. Green is for a normal bone mineral density, yellow is for osteopenia, and red is for osteoporosis. Coming on to femoral, you have to make the patient lie down supine. The lower limb which you are analyzing, you can analyze either right or left, doesn't make a difference. It needs to be slightly abducted with a foot holder strapped with the feet. And these are the region of interest that we have to look on the DXA femoral scan. So you need to have a femoral neck, greater trochanter. So you need to have a femoral neck, greater trochanter, and the ischiopubic ramus in the field, but the lesser trochanter should not be visible. So you need to abduct and slightly internal rotate so that the lesser trochanter is not visible in the field. So the potential errors which are associated with a femoral scan are lesser as compared to a spine scan and are limited to only visibility of lesser trochanter. So you have to rule out if there is any lesser trochanter visible, and you have to rule out if there is any metal implant placed in the picture. So this is how a scan obtained for femur looks like. So what are the contraindications of getting a DXA? So as we all know, since it is a radiation-based technology, it should be avoided in pregnant females. All the metal implants, they should not come in the field of scanning. And a recent contrast study, which is less than 5 days, the subjects should not be subjected to a DXA scan, because if it comes in the field of scanning, it will give you a falsely high BMD value. So how do we get a result? So the interesting thing is that DXA, although a radiological diagnosis, gives you result in the form of a number. No other radio imaging gives you result in the form of a number. So the problem is most of the time radiologists do not report it because they say it is a pathological report giving the result in the form of a number, and pathologists are not trained in seeing a DXA. So ultimately it is the clinician who has ordered a DXA. It is his or her responsibility to see whether it has been acquired and interpreted in a proper fashion or not. So we get the result in the form of a number, which gives in the form of Z-score or T-score. So there is always a tussle whether to use a Z-score or a T-score. And in case you are ordering two regions, suppose you are ordering spine and femur, then you have to see the lowest value among the two. So when to use a Z-score or a T-score? So Z-score is used in premenopausal females and men younger than 50. So all our patients, we will have to use a Z-score. So the basic difference between a T-score and Z-score is that a T-score compares your bone minerals density to a young adult reference, while a Z-score compares the bone mineral density to a patient matched age, gender, and ethnicity. So DXA nonetheless is also associated with limitations, and this is a very important point to learn from here. So DXA, although gives you information regarding density, but it is a two-dimensional density. It gives you an areal density, but what we have been learning in our basic sciences, that density is a three-dimensional parameter. It has a volume. So if we take example of this cube, what we see here is that although the volumetric BMD is same in the small cube and the large cube, but the areal BMD is lesser in the small cube, which means that a shorter child will falsely have a lesser areal BMD compared to a longer child, even if the volumetric BMD is same. So if you are to follow up a child, the child will grow, the bone size will increase. So can you compare the initial report with the current report because the bone size is changing? No. So for this, we have the adjustment for the bone size, which have been given by 3 arithmetic equations. And you don't have to apply these arithmetic equations. These are inbuilt in your DXA machine. This is just for a scientific discussion. And this is known as a bone mineral apparent density. So this was given by Molgard for the whole body DXA. It is a 3-step process which corrects for the age, height, and bone area. For a spine, this was given by the Katzmann et al., which assumes vertebra to be a cube and then gives a corrected bone mineral apparent density by the formula given on the screen. For a femoral neck, Croger et al. Gave us an arithmetic equation for giving us a bone mineral apparent density, considering the femoral neck to be a cylindrical shape. This is a newer concept of comparing the total body bone mineral content with the lean body mass. So scientists say, why are we worried about bone mineral density, which is so much influenced by factors such as size, age? Why do not we consider the bone mineral content as such? And this needs to be corrected for a lean body mass because of the presence of mechanostat theory. So we know if we have stronger muscles, we have stronger bones. So this lean bone mass correlation with bone mineral content is now considered as a new marker of bone strength in pediatrics population. So second limitation of DXA is that we need to use a pediatric software. So most of the DXA machines which are installed in the hospitals, they have an adult software. So you need to check whether your DXA machine is compatible with a pediatric patient or not. So for example, if we see here, this is a DXA done for a patient. So on the left, we have a DXA done by a pediatric software, while on the right, we have a DXA done by using an adult software. So just see the bottommost value of total body done by pediatric machine, which says a bone area of 1810. So what we need to understand is that DXA uses the edge detection technology. So pediatric bones, by virtue, they have a lower bone mass. So if we assess it using adult software, so what we see is that the adult software has limited edge detection technology. So that will not pick up the pediatric bone and give you a bone area of only 1,315. But if the same is assessed using the pediatric software, which has an improvised edge detection technology, the bone area will increase to 1,800. So if you have a higher area, then we all can apply mathematics and see that the bone mineral density will change if the area is changing. So one needs to do a lot of adjustments while acquiring a pediatric DXA. We need to adjust it for the age, gender, height, and size. Over and above, you have to just check whether your machine has a pediatric software, whether that is using a ethnicity-based normative database or not, and that would be enough. So coming on to what are the correct indications of pediatric DXA. So the National Osteoporosis Foundation has laid down the following indications for obtaining a pediatric DXA. So you should order a pediatric DXA only and only when there is a high suspicion of osteoporosis and not as a routine test like complete blood count. So these are the few indications: long-term corticosteroid use, chronic inflammatory disease like inflammatory bowel disease, primary or secondary hypogonadism, because we all know that sex steroids have a role in bone mineral density acquirement, prolonged immobilization, osteogenesis imperfecta is a well-known genetically acquired low bone mass condition, IgAO, which is a diagnosis of exclusion in juvenile population, recurrent low trauma fracture, and apparent osteopenia on radiographs. So this is how a DXA report looks like. So this is the one acquired from Regency Hospital. So it will have a hospital name where the machine is installed, where the DXA has been acquired. Then it will have some patient-related details. Then it will give you a site-based assessment. So this patient was subjected to a spine and a total body DXA. So it will give you separate result for both spine and whole body. And if we are using two-site assessment, we need to check the lowest value and we'll compare with that. And then there is a WHO classification which is not applicable to pediatric population. It is applicable only to the adult population. So here we have two DXA reports. So one is for the whole body, the next one is for the spine. So in whole body, you can see that the machine is giving you two images. So one is for the skeletal and the other one is for the soft tissue mass, because DXA has a role beyond bones, which we will be discussing in subsequent slides. So DXA, which has played an important role in the assessment of bone mineral density, has now slowly found its way in assessment of bone body composition as well. So it gives you value regarding not only the fat mass, but also the lean mass of the total body and also the regional viscosity adipose tissue. So till now, we have been using CT scan to understand regarding the visceral adiposity. But CT scan, you know, is associated with radiation exposure. So DXA is now currently used for research purposes for getting the information on fat mass and lean mass in regional and a whole body manner. This also gives you information regarding the android-goinoid ratio, because AG ratio is associated with the incidence and prevalence of metabolic complications. So the take-home messages from this DXA discussion would be that it should be ordered only in appropriate conditions and should not be used as a routine diagnostic modality. A correct methodology of how the patient should be lied down, what algorithm should be used should be followed. And the same equipment should be followed for following up purposes because of the difference in not only the software, but also the hardware of the different manufacturers. Again, this is a only radiological instrument which gives you result in the form of a number, but you need to understand that just a number of -1 or -2 is not a diagnosis, but you need to have a clinical context.